I want to welcome everyone here for this telehealth seminar. This is, as you all may uh, imagine, this has become a need in terms of providing healthcare services through COVID-19 pandemic. And a lot of us have implemented telehealth in our practice. Our goal is to go through some regulations, rules, some of the changes that we have had through COVID-19 pandemic, where regulations have been laxed to provide the services, as well as providing telehealth in some specific patient population and children and adolescents as well. So in my presentation today, I'll cover some basics of telehealth. We all should be familiar with some basic terminology of telehealth, and this is absolutely very important when if you have a vision of providing telehealth beyond the current COVID-19 pandemic, and if you want to expand and probably understand all aspects of telehealth and make sure that your practice is risk mitigated. So the first definition is the basics or distant or provider site. So what provider site means is site at which the physician or other licensed provider is delivering services is located at the time of the service is provided via telecommunication. It may also be referred as hub site. Amanda, can I have you for 1 second? I need some change here. Is there a way to minimize or change this part? Yes. Because it's blocking the. Okay. Thank you. Thank you much. Okay. Mm-hmm. Okay. So that is a provider side. So telehealth has three components: provider side, and the second is originating or patient site. This is the site where patient is located. So location of the patient at the time of where the service is being furnished via telerepresentation may be needed to facilitate the delivery of these services. It also is referred to as a bespoke site. Usually the originating site is where patient is in their home or in some of the rags around the Medicare, if they are in a rural area, in a community health center. So those are the typical originating sites that we see. There is also another component, and this is more relevant to psychiatrists, primary care physician, other specialists, and that is called as telepresenter. So telehealth encounters require a distant provider to perform examination of a patient or client from many miles away. So in order to assist the provider, an individual at the patient site is often needed to coordinate tasks like handling the equipment, taking vitals, and assisting physicians or practitioner with some basic examination related tasks. Now I'll go through some regulations and also the regs we have for in state of California in terms of providing services and also prescribing medications and so forth. So the first aspect is prescribing, dispensing, or furnishing dangerous drug as defined in section 4022 without an appropriate prior examination and medical indication constituted unprofessional conduct. And this is coming from California Business and Professional Code for physicians. An appropriate prior examination doesn't require a synchronous interaction between the patient and the licensee and can be achieved through the use of telehealth, including but not limited to self-screening tool or a questionnaire provided that the licensee complies with the appropriate standard of care. So basically what it says is when you are providing services, you clearly have to do some sort of an examination, and this examination is not necessarily require asynchronous interactions. It can be image that has been sent by patients to a provider. It can be a video that they have sent it, or it can be um, other form of self-reports, questionnaires, or some other forms of that nature that has been sent. I'll just. Okay, thank you. The other one is public university student health care centers are required to offer abortion by medication technique on site, which may be performed through a telehealth services on or after January 1, 2023. So this is one of the revision in California Education Code for allowing obstetric gynecologists and abortion centers to provide medications via telehealth. Something is not working here. Okay. Okay. Remote dispensing site pharmacies, and this is just a regulation that allows the remote dispensing site pharmacies to permit to dispense pharmaceutical care services in medically underserved area. A supervising pharmacy must provide telepharmacy services to the remote dispensing site pharmacy and shall not be located greater than 150 miles from the remote dispensing site pharmacy. So this is a regulation related to the pharmacy services and so forth. Now there are other regs that the California legislation have come up. One is AB 2315, which requires CDE, California Department of Education, and DHCS, Department of Healthcare Services, to create guidelines for appropriate use of telehealth in public school to provide mental and behavioral health services. So, that what this says is, it's probably appropriate to be able to provide the services into California school system if you have a contract with California schools in therapy services. AB 2576 authorized the governor during the state of emergency to direct all state agencies to utilize, employ, and direct state personnel, equipment, and facilities for the performance of any and all activities that are designated to allow community clinics and health centers to provide and receive reimbursement for services provided during or immediately following the emergency. This authorizes any agency directed by the governor to perform those activities to expend any of the money that have been appropriate to it, that includes telehealth services. And this regulation could be helpful for a lot of our communities who frequently go through fire events in northern as well as Southern California. Now, AB 2861 requires the State Department of Healthcare Services to allow licensed practitioner or the healing arts or a certified substance use disorder counselor to receive medical reimbursement for substance use disorder services provided through telehealth in accordance with Medicaid state plan. So this reg actually allowed all other providers, including certified substance use disorder counselor, to bill and collect from Medicaid state plan, which is state medical in California. And then SP 1023 clarifies that health service plans, health insurers, and medical managed care plans may cover sexual and reproductive health services provided appropriately through telehealth. Now, it is very, very important to mitigate the medico-legal risk factors and also to have a streamlined process for successful telehealth services to be delivered, to have appropriate procedures and protocol. And so, we recommend that prior to initiating telehealth services, any organization or provider should have a place, a set of standard operating procedures or protocol that should include, but are not limited to following administrative, clinical, and technical specification. So basically, there should be a mini manual that takes into consideration about how the telehealth services would be delivered. And in that, one can define roles and responsibility, daytimes, hour of coverage, communication, procedures, if the emergency, if it should arise. There should be also agreement to assure licensing, credentialing, training, and most importantly, authentication of practitioner, as well as identity authentication of patient requiring local, state, and national requirements. And there should be a systemic quality improvement and performance management process that complies with any organizational, regulatory, or accrediting requirement for outcome management. So basically, the group who is providing telehealth services should have this sort of a procedures and protocol be in place in form of a sort of a manual. And one of the important component of this that I want to mention here is when you are providing telehealth services, it is very important to identify before starting the session who you are. So I would say something like, I am Dr. Shah, I'm a psychiatrist, I'm an MD, I work for Sian Clinical, and here is my badge, or here is my identification. And then it is also very important to identify and get some credentialing information from the patient. So you could say, please let me know your name, your date of birth, and other identity, or your home address, or the location where you are in, so you can verify the patients. And this is also critically important aspects when you are looking at mitigating the malpractice risk, which I'll cover later in this session. One of the very important topic that frequently is brought in discussion is the patient safety. What do you do if there is a crisis? How do we handle that? So I think our recommendation is that when you are evaluating patients, it is absolutely important to first figure it out where the patient is. So find out what is the location of the patients. And you can do that, like I said in my previous slide, at the beginning of the slide, you can ask a simple question like, where are you located? Are you in a home or clinic, or where you are? And then, so if there is any crisis protocol that if you need to activate later in your evaluation, then you can utilize a patient's contact information or location information effectively. Also assess the level of agitation, potential for harm to self and others, and other safety hazard that might be accessible to the patient during the session. So, for example, if you have a patient with frequent parasuicidal behavior, it is useful to figure it out where they are. Do they have access to any, are they in a safe surroundings? Do they have any access to any instrument or anything that could be utilized to hurt themselves during the session? For example, they have a metal rod. I was doing a telehealth session a few years ago, and my patient had a history of severe suicide, and he was doing that from his relative's home, and he had a sharp rod in his office, not in his room. So I think it's very important to query the environment where they are from the safety point of view and so forth, and ask them to first remove them before you start your sessions and so forth. And if you are providing services to originating site, and this is usually occurs when the patient is located in a rural area, generally in a community health center, and you are a provider on a distant site, then it is useful to find out what the emergency protocol for that particular site is, what is the what you could do in terms of involuntary hospitalization, as well as changing the level of patient observations. So it's probably useful to develop that relationship with the originating site staff and figuring out what their risk management protocol is, And when you use technology, your technology should be to be to allow you to manipulate the image and sound quality of the video during the sessions, so that you can so it allows you to inspect patients' verbal as well as visual cues for agitation or other possible factors that is related to patient safety. So you should be able to zoom in, or you should be able to look at their expressions a little more closely, and you should be able to hear them very clearly. And those are some of the basic requirements and some of the basic elements that one can take into consideration while evaluating patient safety. Other thing is clinical documentation. Clinical documentation of telepsychiatry encounter is an important, as with any other clinical encounters, but there are some important additional consideration, including a special need for that you should take into consideration. One is documentation in your progress note about the time, date, and remote site location. So you should look into documenting where the patient is, their home address or relative's address, or where they are actually located. So that should be included in your charting. Documentation of duration of the encounter and the time spent in face-to-face evaluation with the patient. This is especially important if you get audited in the future, which doesn't seem like a possibility at this time, but it's something we all have to be wary about in upcoming few months, where our charts may get audited through an insurance company or a third-party auditor. So please include the face-to-face time, and this is also very important when the patient disputes about the services that you have rendered it by either calling the insurance company or creating any frivolous claim with the medical board. Documentation of originating site location and personnel. So if you have a telepresenter, please make sure you write about his or her name and also what the role that that person would be serving to assist you during the telehealth services delivery. I would definitely recommend reason for encounter, treatment for depression, chief complaint, referral sources, history of present illness, current treatment including medication and ongoing therapies, mental status examination, very important to document, and that will also help you meet the coding requirements, diagnosis and treatment plan, and then obviously the other parts like past medical, family social histories, and review of systems are very important to include. Now they have done plenty of research about the clinical outcomes and whether the telehealth services are as effective as face-to-face evaluations. And for certain pieces, the telehealth services comes out to be good. For some, is excellent, and for other ones, we still need to work. So first of all, the prerequisite for good outcome include first the excellent clinicians, the clinicians who understand the technology, clinicians who has a good presence of mind about facing them with the patients and your surrounding background. So that is, and then also just kind of delivering the services and your comfort level with audiovisual equipments or third-party software. So excellent clinicians have always an excellent outcome, whether it's a face-to-face or telehealth. So we as a providers are number one equation into what the outcome may be for your services that you're providing. Program fitness in terms of organization, functions, leadership, and right member and workforce. So this is more applicable to institutions which are offering telehealth services. So essentially, it becomes for an institutional project They have to have a right infrastructure, leadership, right members in terms of the administrative and clinical team, and they have to have a very well-defined workflow to have a successful telehealth practices. And technology obviously is a very important, high-speed internet and also a good audio-visual communication method is a very, very important aspect of delivering a successful telehealth services. And generally that is not an issue, as in this turn age we all have a broadband internet and enough bandwidth to provide the telehealth services. In terms of feasibility rating, when they did studies, the technical aspects generally came out to be significantly positive, and it had an outstanding ratings when they reviewed multiple telehealth areas in multiple sites. Validity testing was also outstanding. Reliability testing was also outstanding. Satisfaction rating for patients and providers were also outstanding. And cost and cost effectiveness for rating was also similarly very good. So the clinical measures for the ratings that were used were interviewing, assessment, cognitive testing, and others. And they all measures turn out to be outstanding. For dozens of clinical scales, they have been shown to be reliable and valid. And telehealth has been used for a variety of psychiatric disorder evaluation and treatment, including patients who have paranoia, substance abuse problem, cognitive problems, and they come out to be fair in terms of overall results. And the settings generally has also been pretty positive, except they say we need to do a lot more work in the emergency room setting, jails and inpatients, as well as in school. This site seems to be not that well prepared for delivery of good clinical outcome for telehealth services. I'm sure Dr. Desai, our child psychiatrist, will speak more about child psychiatry and telehealth, but what I have read is children and adolescents on autism spectrum, it may be preferable to do in-person evaluation rather than telehealth. I just read, so I thought I would include. We'll let Dr. Desai clarify more about this. Other than patients who have disabling anxiety, severe panic disorder, post-traumatic disorder, veterans, they usually it is preferred services. I'm sorry, I want to go back about child and adolescent with autism spectrum. It may be preferable to in-person. So, and I think I spoke other way around. So it's actually it's preferred that you do telehealth services rather than in-person services. For adults with disability and anxiety, it is preferred that telehealth services are preferred over the face-to-face evaluation. And preliminary studies in geriatric patients and across cultures are positive. Indeed, it may facilitate cultural, ethnic, language matching between patients and provider. And the experience with therapies in trending very positively with surprisingly very few problems. So all in all, I think there has been a positive result. Now, I also want to talk about Haight Online Pharmacy Consumer Protection Act. This is more applicable to MDs, psychiatrists, and this act one has to really take into consideration while prescribing controlled substance. And so basically Haight Online Pharmacy Consumer Protection Act of 2008 was created to regulate online internet prescriptions. And that has been strictly enforced by DEA, and also imposes rules around prescription of controlled substance through telepsychiatry. The act requires any practitioners issuing a prescription for a controlled substance to conduct as an in-person medical evaluation within a certain specific exemptions. A conservative recommendation to support compliance with the Act is to conduct an in-person exam at least once every 24 months. So if you are providing telehealth services, it's good to keep this in mind, that if you are giving any controlled substance, then to see your patients once every 2 years. And that is just a recommendation under this Act. The Act also describes special circumstances such as covering prescriber and prescribing within a federal care systems, for example, Indian health systems, Department of Veteran Affairs, and the psychiatrists working in federal healthcare system should be familiar with their organization's policy around the telepsychiatry prescribing of controlled substances. In addition to complying with the Ryan-Haight Act, psychiatrists needs to make sure that they comply with other federal, state, and organizations' rule and policies around prescription of controlled substance. Now, next one is telehealth and malpractice issues. The important take-home messages is, before you start providing telehealth services, please make sure to give a call to your insurance company to ensure whether the telehealth services have been covered under your malpractice insurance policy. We all generally presume that it would, but that is not necessary. Some malpractice providers covers telepsychiatry as part of their standard coverage. Other malpractice carriers have additional policies and may require additional coverage for when providing telehealth services. So you may have to pay extra for including telehealth rider. Some companies offer coverage that include the practice of telepsychiatry, whereas some carriers require purchase of additional coverage for telepsychiatry on top of existing insurance. And prior to engaging into provision of telepsychiatric care, psychiatrists, or in this case also the other providers, should check it if specific telepsychiatry services that they will be engaged in are covered by the existing malpractice carrier, as I pointed out. One other aspect that frequently comes into discussion is recording of session. I get asked this: what if my patient is recording my sessions? And I have a difficult patient. I have a patient who has serious parasuicidal behavior. She has a history of being involved in litigations, and I worry if I provide services, my patient will record and use against me in court of law. So I want to bring this into your consideration. In state of California, recording of session is considered as illegal as long as there is without a mutual consent of both the parties. So if you and your patient, you both don't mutually consent for recording to the session, it is considered as illegal and it cannot be used in a court of law. And it is extremely important to clarify this before starting your session. So for example, I do this, and I also tell all our providers here at CIAN to follow that before they start the session, even if they are their existing clientele or if they are the new patients, to say something like, I am not recording this session and I would like you not to record this session. If you record this session, I may terminate this session as soon as I find out. So something like that, if you verbalize before starting your session, it would be very, very useful. And then I would document that in your progress note, that you are not allowing recording of sessions with patients. Now, of course, if you are a therapist and you have a practice in which you and your patient have a contract and they come with a recording device and they typically record your session and you feel comfortable, that is fine. But if you don't have the practice and those agreements set with your patients, and this is something one should look carefully consider. Now, this is probably one of the very important aspects that a lot of you may have questions, and As you all know, COVID-19 pandemic has changed a lot of things, and it has changed and provided flexibility in a lot of the CMS, HIPAA rules, and I would say this is probably a temporary flexibility as by CMS, and it is equally very important to know what the telehealth looks like once this flexibility is taken away. But let me go through some of the flexibility that has been given to us by CMS, HIPAA, and Office of telehealth resources regarding this flexibility. So on March 30, 2020, CMS published an interim final rule regarding Medicare and Medicaid program, policy and regulation provision in response to COVID-19 public health emergency. To provide additional flexibility to physicians during COVID-19 pandemic, the following changes that came, and I'll just read all these changes for you so I don't miss out on anything. Added medical coverage of and the payment for telephone evaluation and management. These are the E&M code 99441 and 99443, and these services may be provided to new and established patients. So if you are making brief phone call to a patient in between your regular session, you can utilize this E&M code to bill for it for a short phone call that you might be giving to your patient, that you might be utilizing to communicate with your patient. Allow physicians to select the level of office outpatient E&M furnished via Medicare telehealth based on medical decision making or time. So that is kind of not changed much, except the requirement for Medicare to reimburse if patients' locations should be in a rural area and also in an originating site. That has been eliminated. So it stands right now. If the patient is at their home, you can still see them, bill them, and Medicare will pay you for your services. Clarify the Office of Inspector General's policy statement to state that the physician will not be subjected. When I say physician here, because this is what they have used in their language, but it also applies to all clinicians, including therapists and including psychologists, social workers, MFTs, and all of the mental health providers, as well as medical providers. Stated that physician will not be subject to sanction for reducing or waiving cost sharing for a broad category of non-face-to-face services that includes telehealth visits, virtual check-in visits, e-service, e-visits, monthly remote care management, monthly remote patient monitoring. Now, so just the implication of this rule is, as you all probably may know, that if you are treating a Medicare patient, you can never ever in any situation can waive a copay or deductible that is applicable to the patient. If you waive, and if you have a practice that is typically set up to reduce or waive copay for a Medicare patient without having any applicable policy, that can be used by Medicare as a fraud. And we have many colleagues in the past who have got into trouble with Medicare for waiving or reducing or their copay. And probably they had a great heart about helping patients, but the law doesn't allow you to do it. But in this particular situations, through COVID-19, if you decide to waive a copay or reducing your sharing, then I think you should not. You are allowed to do that. So that's one aspect. Expand the list of services that can be provided by telehealth. Provide payment for telehealth services at the non-facility rate. So this is a very, very good news for all the therapists. We are getting paid at a non-facility rate, so which is a little higher reimbursement than the facility rate. And then we should use place of service as modified 95 for Medicare claims. And then any services reported with POS 02 telehealth These are generally the services which typically we bill at the originating site, which probably doesn't apply to majority of us, but for example, there is small reimbursement if the patient has checked into an originating site and the vitals are taken at the originating site, then you can all bill that. However, all that will be paid through facility rate and not as non-facility rate. Allow telehealth virtual check-ins, e-visit, telephonic A&M services to be provided to any patients, new or established. Clarify that the consent must be obtained annually and may be obtained either before or at the time of services. So it's also very useful to develop a telehealth consent form and then go through this and you should try to update that annually. That's a good practice as well. And then HHS won't enforce penalties for violators of certain provision of HIPAA. Privacy rules against healthcare providers or their businesses associated for good faith disclosure of protected health information for public health purposes during the COVID-19 emergency. And this allowed us now to use telephone. This allowed us to use any telecommunication devices to deliver services. Before that, it was very stricter rule about using only HIPAA compliant approved telehealth software. But now this allows you to also use other methods like FaceTime and Skype and also the regular telephone call. And that is only through COVID-19 emergency. So with that, I'm going to finish. I'll take more questions when at the end of, and then I'd like to invite Dr. Desai to come and present her part. Thank you.
Thank you, Dr. Shah. So I wanted to remind everyone, if you haven't already, in order to qualify for CME or CE credit, please sign in the chat box. We do need your full name, your degree, and your email address in order for me to return a certificate to you after I receive an evaluation form. So I'll go ahead and hand it over to Dr. Desai.
Good evening, everyone. I'm Dr. Preetal Desai. I'm a psychiatrist, MD, with a background in Masters in Public Health and with a subspecialty in Children and Adolescent Psychiatry fellowship that I did at the University of Virginia in Charlottesville. I see patients 5 years and above at SIAM Clinical Research in Santa Rosa, California. I would like to start with my first slide, talking a bit about the current issues we face in child and adolescent psychiatry. The main issue we have is demand versus supply. There are about 13 child and adolescent psychiatrists per 100,000 youth nationwide currently, which is a huge deficit compared to the need. This leads to a workforce shortage. Additionally, there is maldistribution of providers. Most of the providers work in urban setting, leading to minimal or no child psychiatrists available for rural underserved areas. This leads to, as a result of the shortage, it leads to many youth going undiagnosed for many years. And secondly, less than optimal treatment. Sometimes youth prematurely are discharged from the ER without proper follow-up plan. So all of these issues lead to a lot of undiagnosed patients, increase in mental health issues, and resulting failure to perform for the youth for their future and life. Given these issues, telepsychiatry has played an important role in child and adolescent psychiatry, increasing the access to care. And we are still, as a nation, we are still working towards optimizing that platform. of telepsychiatry. So next slide, I want to talk about the benefits of telepsychiatry. Dr. Shah already mentioned about the evidence-based support that we know about in the telepsychiatry, and studies of feasibility and accessibility of telepsychiatry. Research has shown treatment delivered through telepsychiatry is as effective as in-person treatment. Additionally, telepsychiatry works on patient-centered model of care through home-based intervention. Now, home-based intervention addresses two critical and important issues in child and adolescent psychiatry. They are number one, which is addressing the school attendance issues. Children and adolescents have to be removed from their school to come for a psychiatrist appointment. Many times the psychiatrist clinic is away, so they have to take half day or full day off from school, especially if they're living in rural areas. I have some patients who drive 4 hours each per day to come for appointment to see me. So that is a very critical issue. And secondly, parents' work schedule issues, that loss of wages for the parents as they have to take time off from work. So telepsychiatry addresses these two important issues and also decreases transportation costs for the parents and family. In addition to that, there is populations such as autistic youth may prefer home-based intervention. Dr. Shah briefly mentioned about this, and I would like to explain a little bit more on this, that because we all know that one of the key features in autism is their difficulty with transition of their routine, or change in routine, or change in their schedule can elicit a lot of anxiety and agitation for those children and adolescents. So being at home or with home-based intervention, that it can mitigate this issue for them. So telepsychiatry can play a very important role for autistic youth. Overall, telepsychiatry decreases healthcare costs, mitigating the problems by addressing the issues at an early stage. For example, a depressed youth who has a regular follow-up with a child and adolescent psychiatrist may be well managed, but if someone who has not been well treated or well followed up, they may worsen to the point of suicidality, hospitalization, resulting in increased healthcare costs both for the family and overall for the system. So telepsychiatry can help in earlier intervention, prevent higher level of care, and in turn saves resources for them. Now, next slide. I'll skip the slide since Dr. Shah has already mentioned about the Haight Online Consumer Pharmacy Protection Act of 2008, which also applies to child and adolescent telepsychiatry, and it has some relevance to the home-based intervention, since it is home-based setting is not approved site of service for prescribing controlled substances. So this act does affect that setup, and Congress has released draft discussion bills to amend Haight Act. And as of March, with the pandemic situation, it has been suspended, so we'll see how it goes in future. The next slide, briefly touching base on legal and reimbursement issues. Definitely consult federal and state law, state medical licensing board, and DEA before initiating telepsychiatry. In addition to the usual consent for care, it's important to get guardians' consent for telepsychiatry services for the youth. It's also important to look into reporting requirements, which may vary by jurisdictions. Reporting of child abuse or neglect, what are the requirements per jurisdiction, within how many hours are you required to report, verbal report, written report, etc. Next, reimbursing for school-based telepsychiatric services. In the absence of a comprehensive policy for delivering telemedicine services, individual states have proposed legislation to expand services in several ways, such as reimbursing for school-based telepsychiatric services, or repealing laws that mandate minimum distance requirements between distant and originating sites, and some states that require coverage for telepsychiatry services for specific circumstances or disorders such as autism intervention. Now, next slide, I will just touch base on patient safety and emergency management. The emergency management at a telepsychiatry site is a team effort. On-site staff must be identified and trained for emergencies. Community resources must be identified to incorporate into emergency management protocols. Psychiatrists need to be able to effectively manipulate telepsychiatry technology in order to maximize video and audio quality to optimally assess signs of agitation, substance use, and medication side effects. And if the technology falters, the psychiatrist should be well prepared and aware of a pre-planned backup emergency management plan, which can be quickly initiated in such emergencies. Now, seating and related challenges in youth. So here, the first point is if there is one participant on the remote site, then the guidelines state that you should have 2 to 4 feet distance from the camera and the screen, and with each additional participant in front of the camera, additional 2 feet away from the camera is required. So that would require a larger room to accommodate that, so that everyone is in a decent frame and fits into the camera frame appropriately to be well assessed by the provider. Now, children can sit in different arrangements. Children can sit next to the parents. They can be seated in between the parents or on parents' lap if they are younger kids, or in front of the parents in a chair or on the floor, whatever works and whatever is comfortable for the family, as long as they are within the 2 to 4 feet distance from the camera and everyone is fitting in the frame. Now, few of the scenarios which we may come across while assessing a patient on telepsychiatry platform are if we are coming across hyperactive or autistic child which cannot remain in front of the camera. So in those situations, what can be considered is consider keeping the parent in the camera frame and call the child back into the frame when they need to answer a question. So while you're talking to the parent, you can allow the child to play on the side. You may not see them very clearly in the frame, but then when you want to assess them or ask questions, you can bring them in. So in that way, they don't have to continuously focus on the camera or be worrying about them being able to sit still. Now, if a child's motor skills or behaviors or movements are being assessed, then we need a larger room for this kind of activity to fit within the camera frame. Secondly, occasional anxious or defiant child or adolescent who refuses to sit within the camera frame. Now, in these situations, first approach that we would want to take is behavioral management strategies. If the behavioral management strategies do not work or fail to move the youth, then prior to the next session, we can instruct the parent or the session facilitator to turn off the self-monitor image and seat the youth farther away from the camera so they remain in the frame. And another strategy is to allow the youth to have more privacy for part of all of the session. So these are the few ideas how we can approach certain situations that we may encounter in children, more so younger children and also anxious and children with behavioral issues or autistic children. Now, to summarize on this, paying attention to room selection, the size of the room, number of participants, the arrangement of the participants, and other aspects of nonverbal communication plays an important role. This is where providers' experience working and sufficient practice can help in ultimately getting comfortable and confident in matching the telepsychiatry platform to an in-person office visit. And one very important thing that we need to be mindful as providers is our own nonverbal communication, because although we have advanced technology these days, but the Wi-Fi, the route, the internet speed can vary from one end to the other, and in that the subtle verbal expressions, body language may be missed, and it may be misinterpreted by a patient, especially if they're paranoid or have personality issues or anxiety. So it's very important as a provider for us to be more aware of that. For example, if you're waving hello or goodbye, you have to do a little bit of extra movement on the camera than what you would do in general in an office setting, just so that it's more visible and more obvious to the patient. And another point I want to mention about doing telepsychiatry assessment is forms and rating scales that we often, all of us, use. So those can be sent through email packets or mail packet to the remote site or to the patient's address, home address, and they can be sent back by them through email or fax or whatever may work for them. And additional rating scales can be included based on the referral question that the patient has in place at the initial form that they fill out. There's one other thing that has been available, which is called whiteboard which is inbuilt in video conferencing camera. This can be used for some of the assessments where you may want to do some, not exactly rating scales, but draw test or sentence completion test or memory test during the session where you want patient to draw something. So those whiteboard, which is inbuilt in the camera, video call can be utilized. So this is about the seating and some of the different scenarios that may come up in telepsychiatry assessment. Next 3 slides, I just want to speak a few specific points on different settings that are used in child and adolescent psychiatry. Now, community mental health settings. Child and adolescent telepsychiatrists may play an important collaborative role to upgrade evidence-based child-specific services. In rural areas, child and adolescent psychiatrists can help bridge the access to care gap by referring youth back to the primary care provider for medication management after evaluation or stabilization. In addition to that, the child and adolescent psychiatrist must learn to work within the structure and resources that are available in the under-resourced community mental health center. It's also important for the telepsychiatrists to establish a strong working relationship with the local team to develop social and cultural competence to be able to assist and help the patient on the other end. Next is school-based Next is school-based telepsychiatry. Now, school-based telepsychiatry reduces parents' work leave, it decreases children's absences from school, and increases their attendance at psychiatry appointments. In addition to that advantage, it also helps to build a team for child and adolescent patients with collaboration among psychiatrists, educational staff, parents, and youth. And the last slide on juvenile population. Child and adolescent psychiatrists should be familiar with jurisdictional regulations regarding consent to pharmacological treatment of minors in correctional settings. The psychiatrist must define their role in youth system of care and treatment. For example, it's very important for the provider who is assessing the youth in the Department of Juvenile System to clarify their role, whether it's a forensic role or a direct patient care role. On-site therapists typically participate in sessions to aid the psychiatrist in obtaining pertinent patient information and to facilitate clinical care. Correctional staff typically do not participate in sessions as youth may be concerned about privacy and or repercussions during incarceration. So that ends my talk, and would be happy to take questions towards the end. Thank you.
Thank you, Dr. Desai. I'd like to remind everyone, if you have any questions, to please enter them in the chat box, and then we'll review all of the questions at the end. And also, if you haven't already, please sign in. I'll need your full name, your degree, and your email address in order to qualify for CME and CE credits. And here's Aubrey Vance-Tobry.
Hi everyone, thanks so much for joining us this evening. My name is Aubrey Vance-Tobry. I am a licensed clinical social worker and psychotherapist for Sion Clinical Research. I work about 50% of my time with opiate use disorder population, recovering from opiates, and they're recovering through medication-assisted treatment and psychotherapy. And the other 50% of my time, I am working with patients struggling with anxiety and depression, so mostly with adults 18 and up. According to Mental Health in America, 65% of adults with a mental health disorder have gone untreated. Out of the 65%, roughly 22% of those adults, that's about 1.2 million people, say that they don't have access to mental health services. So why is that? Where did we go wrong in our system? First, I want to acknowledge that there's a shortage of mental health care workers. It includes psychiatrists, case managers, therapists. So that's a big reason. But as to why people don't have access to mental health care, there's also insufficient finances, poor referrals from primary care, and health insurance. One of the biggest reasons, though, why people do not access care is because they live too far in rural areas, or the appointment times are too long. Telepsychiatry has created access so that nearly everyone has the ability to receive mental health care right from their home. And now more than ever, more therapists and psychiatrists are utilizing the telehealth platform because of COVID-19. So there's going to be some overlap with the other presenters, but first I want to cover the regulations that apply to marriage and family therapists, licensed clinical social workers, and licensed professional clinical counselors. So let's start by getting the legalities out of the way. According to our California Code of Regulations 1815.5, we want to make sure that our initial psychotherapy visit with the patient has the same standards of practice as we would an in-person visit, with the exception that we discuss the risks and the limitations with using online services. Also, we want to obtain the patient's location and identify resources in the area in case of emergency. Make sure that we document all of that in our progress notes as well. It's imperative we explain the potential risks of using teletherapy, as it's not as secure as meeting in person, and get the patient's consent before we proceed with the visit. Now, for every visit following the initial visit, we want to confirm their name, their location, and assess their suitability for the visit. For example, if someone's under the influence of alcohol or drugs, they have active psychosis, they're suicidal or they're homicidal, we need to assess those things right in the beginning and make sure that they get the care that they need. So we're going to refer them to the right level of care or contact 911 and send to their location. Just use your best judgment, just like you would in the office. So now that we've covered the law, let's talk about the pros and the cons. So a lot of the research about teletherapy is in support of this platform. A lot of research, in fact, there is a little to no research that patients are improving more in the office than they are doing equally well online. So many patients report feeling more secure, they won't run into anyone at the office, and they enjoy having the privacy at home. And the average number of patients that return to a session is 1. So it might be because they live far away or many other reasons, some we don't know, but the likelihood of someone being able to log on from the comfort of their own home is actually going to increase probably the amount of sessions over time. So for example, now there's a variety of specialties. So we have access to all these different types of therapies just right at our fingertips. One of the newer methods for treating shock trauma is called NARM, Neuroaffective Relational Model. A lot of the therapists are trained in Northern California, and people in Southern California don't have access to that type of therapy. So now you can find your therapist online, and in Southern California, access that. So another really great benefit to doing teletherapy is, for example, can you imagine being at home with a sick baby? You may have to cancel your appointment in the past, whereas now you can just log on to the computer and meet with your therapist while the baby's napping in the other room. So let's talk about the cons. Some of our patients don't have access to a private location, or they live in abusive or threatening environments. And for those patients, it might be more beneficial to meet in the office. We always want to make sure it's the patient's choice first. So other considerations that may make teletherapy challenging are if the patient has poor internet connection, or if insurance doesn't cover teletherapy. And lastly, we just want to confirm the patient location, because one of the reasons we want to confirm their location is because we want to make sure our license is in that state. So if the patient is in Arizona and we are licensed in California, that's not going to work, and so we're going to schedule our appointment when they return. Now let's talk about the benefits for therapists. I think up until COVID-19, telehealth has been pretty controversial. A majority of us are now using this platform and hopefully seeing the evidence that our patients are still getting the same benefits as in the office. One of the benefits are an increase in personal safety. So we don't always have the patient's history when we meet with someone for the first time. So imagine meeting with someone over an online platform, and they might have anger, impulsivity. You're going to feel safe because that distance is there, and you can take the necessary actions to ensure that that patient is safe. We're also seeing reduced financial burden for therapists because they don't have to pay for office space, and they're working in a private space in their home or somewhere else that has a lot of privacy. I personally work in the office. I prefer it that way, but for some therapists, they find that a benefit. By saving drive time to and from work, therapists are also noticing an increase in work-life balance, and they're able to spend more time with their loved ones. Lastly, there are many populations that therapists want to work with, but they never had the opportunity. So we're seeing some of the jails and community health centers, schools do contracting work with therapists, and that they're able to do that over the telehealth platform. So like I mentioned earlier, the research shows that there's no difference in the delivery of individual, group, or marriage and family therapy online or in the office. In fact, special populations are reporting that telehealth is more effective because it reduces barriers that arise, such as physical limitations and high social anxiety. I've noticed specifically with my patients that have trauma-related disorders that they're opening up more and they're processing their trauma online more than they did in my office. There's more research showing that cognitive behavior therapy has been proven effective for patients through telehealth platform, and that there really hasn't been any recommendations to exclude certain types of therapy. There's actually been 2 cases with eye movement desensitization reprocessing that have been conducted through video teleconferencing, and they've been proven to be effective. And I think that therapy is typically performed in an office. So this is definitely groundbreaking for us as therapists. I have conducted not only individual CBT sessions, which is cognitive behavior therapy, and dialectical behavior therapy in groups, and I found it really easy to navigate. My patient attendance actually increased for group, which I found extremely shocking and also really satisfying. So lastly, I just want to make sure that I emphasize how important it is for building the therapeutic relationship. When we're using this platform, a lot of people are really uncomfortable. This is new for a lot of people, even though it's been around for a while. So we want to make sure that we're authentic and that we build rapport with the person. It's our job to make sure that the patient feels comfortable and safe, and we want to make sure that they know that we can help them navigate how to get online. So let them know it's okay, that we're going to walk them through it. Without our rapport, really, no therapy is effective, and therapy certainly wouldn't be effective. So just be yourself and be the therapist that you would be in the office, just online. Thank you so much, everyone.
Thank you, Aubrey. Hi, my name is Amanda. I'm Assistant Project Manager for CON Clinical Research and Corporation. I'll be talking about insurance and reimbursement, so some fun stuff. And first I want to start with the Telehealth Resource Center and describe a little bit about what they are and who they are and why they're there. So the Telehealth Resource Center, there are 12 regional resource centers, so it covers all 50 states and the Pacific Basin. And there's 2 national telehealth resource centers. And basically what they are there for is to establish and provide assistance, education, and information to organizations, including CON Clinical, who are actively providing or interested in providing telehealth as a program within their practice. So I included a link there in case you're interested in looking up what your regional telehealth resource center is. They're very helpful. And I also have a link here for some trainings that they offer online, which are also very helpful. So I'm going to go into administrative protocols. Dr. Shaw mentioned a few earlier. Having a telehealth manual or some sort of guide is helpful in practice. It's best practice to have something like that. Some things within the manual that I think are key are having a patient selection form or more of a screening form that identifies and helps you screen out patients who may not be appropriate for a telehealth visit and may need to come into the office for an on-site visit instead. So having a process for referrals. So when you want to refer a patient out, or if a patient gets referred back in, what does that look like? A process for scheduling cancellations and no-shows. So let's say you have a patient who no-shows, what do you do? Do you pick up the phone and call them? Do you schedule a follow-up, or do you have your staff reach out? What do you do in that case? How do you assess physical surroundings in your patient's room or wherever they're joining from? And then also your own surroundings as a physician. So staffing, it's important to identify staffing roles. So who's going to be taking the vitals, who will be helping collect co-pays in your office, reaching out for reminder calls, assessing the patients in originating sites and things like that. So identifying all of those staffing roles is important in the beginning of implementing a telehealth program. Security and emergency protocol. So having a HIPAA compliant software. Of course, during the coronavirus, that is laxed at the moment, but having a HIPAA compliant software is a standard of practice. And then emergency protocol, so having an intervention plan lined out in your manual as to if the patient needs a crisis intervention or if you need to call 911 while they are on the visit with you. 2 forms of authorized consent. In California, you can do documented oral consent and or a written patient consent prior to the service. So best practice is to do both. You can have a documented oral consent, or you can have a written consent that they authorize to join in telehealth visits ahead of time. So it could be one or the other or both. Some provider requirements that I want to mention again, and I think a few of the providers have already mentioned this, but professional licensing is regulated by each state. So basically, A license is required in the state that the patient is located at the time of service, and the physician will need to have the license in the same state. The location of the patient must also be documented to make sure that you're in the same state as them, and as well for a crisis intervention case if you need. Dr. Shaw mentioned a standard greeting at the beginning of visits. So basically what this looks like is it allows you to state any disclosures, any information, identify your physician identity, confirm the identity of the patient, and things like that. So I have an example here of that, and I'll just read it out loud to you. It's, "Thank you, Jane Doe, for participating in our telehealth appointment today. Before we start the session, I need to do some housekeeping with a few disclaimers. My name is Amanda Anello, Assistant Project Manager with Sion Clinical Corporation. And in order to proceed, I'm required to obtain a verbal consent from you to participate in this telehealth visit. Do you consent?" And then they say yes. If they say no, then you can end the session. If they say yes, then you can say thank you for providing consent to continue. I also would like to disclose that I will not be recording this session and ask that you also not record. If I observe the visit being recorded, I will have to end the session. I am providing you a safe and private setting during this visit, as I do with an on-site visit. I know we have met already, but may I ask you to list the following as standard to verify your identity? And then you'll need their full name, date of birth, physical location that they're joining from. And then you can say, "Great, thank you for joining, let's get started." So that's just an example. Now for some billing and reimbursement information. I want to mention that this is for informational purposes only and should not be regarded as an all-inclusive billing or legal advice. So please consult your regional telehealth resource center, which I mentioned earlier, and a legal counsel before launching a new telehealth program. Some things that we'll cover are Medicare, Medicaid, billing and originating site facility fee, private payers, and some general telehealth billing requirements. So for Medicare services, they're traditionally limited to certain geographic locations and to select healthcare facilities and providers as defined by the federal law, while Medicaid policies are state dependent, so each state is different. For Medicaid, in 2018, the Center for Connected Health Policy reviewed reimbursement and found that 49 states, and Washington, D.C., provide reimbursement for some form of live video and Medicaid for fee for service. 15 states reimburse for store and forward delivered services. 20 states reimburse for remote patient monitoring. 9 states reimburse for all 3 of the modalities, live video, store and forward, and RPM. And then 32 states reimburse for an originating site, which is the patient location, facility fee, and or a transmission fee. Although Medicaid programs may cover a telehealth model such as live video encounter, there may be stipulations including only covering certain clinical services, limiting where the patient may be located, or some other requirements. So for California Medicaid specifically, they have a provider manual that lists some billing codes that are eligible, and those include office or other outpatient consultations and visits, psychiatric diagnostic evaluations, pharmacologic management, psychotherapy, critical care telehealth consultations, store and forward services, originating site facility fee, and transmission fee. So those are 2 separate. And then Medi-Cal does not cover telephone calls, electronic mail messages, or fax transmissions. If you're interested and need to know more about Medi-Cal, they have a manual that provides additional guidelines, including billing requirements and patient consent, licensing, and some other basic technology standards. So for Medicare fee-for-service program, they follow a federal law to reimburse for interactive audio with video telehealth services provided by eligible practitioners to patients who are located in rural healthcare facilities An eligible facility for Medicare must be located in one of the two, so a county outside a metropolitan statistical area or a rural health professional shortage area located in a rural consensus tract, what it's called. So some Medicare requirements is to review the complete requirements for Medicare fee-for-service telehealth, review the Medicare Learning Network Telehealth Service Booklet, that's the name of it, to check if a healthcare facility is in an eligible rural area in order to serve as an originating site. So they have a tool called the Medicare Telehealth Payment Eligibility Analyzer, which you can just put the address in of the facility and it'll tell you if it's an eligible area. So to confirm if your proposed service meets all the requirements for a telehealth program, you're encouraged to contact your Medicare administrative contractor to answer any questions and give you confirmation. Some Medicare exceptions to providing telehealth are chronic care management services, remote psychologic monitoring, teleradiology, substance use disorder with or without co-occurring disorder, flexibility for Medicare Advantage plans, exceptions for end-stage renal disease, and then for telestroke services as well. So for Medicare and Medicaid, the originating site fee, basically what that is Medicare and Medicaid programs, they'll pay an originating site fee for a healthcare center who provides an office or a hospital space for the patient. So a facility that hosts the patient. Usually Medicare reimburses about $26, and then for Medicaid, it varies by state. So it could be anywhere from $16 to $50 reimbursement. Medi-Cal is unique in this sense, and it reimburses for an originating site fee as well as a transmission charge. For FQHCs and rural health clinics, Medicare and Medicaid allow FQHCs and RHCs to serve as an originating site for telehealth services, and they may bill as the originating site with a fee if the site is located in a qualifying area. However, FQHCs and RHCs are not authorized to serve as a Medicare distant site or bill for the most professional services through telehealth, or bill for most professional services through telehealth. So for private payers, reimbursement for telehealth varies by state. So 38 states and Washington, D.C. have laws that govern private payers' telehealth reimbursement. Ultimately, most organizations will need to reach out to their payers directly to determine what is covered. Some general billing requirements is when submitting a claim to a payer, the same billing code that you would use if the service was provided in person may also apply for the telehealth visit. However, the American Medical Association has created some telehealth specific billing codes. Many payers will require the claim be submitted with a code modifier, which might include GT for interactive audio and video, or modifier 95 for telehealth specific codes. Some payers may also use the place of service 02 for telehealth. So again, if you guys have any questions, please make sure to enter them in the chat box and we'll answer them at the end. For billing Medicare, the billing code must be included in the list of eligible telehealth services, and it must be submitted with the place of service 02 code for telehealth. Previously, Medicare required an interactive audio and video claims to be submitted with the GT modifier, but effective for the calendar year of 2018, the GT modifier is only required for some critical access hospital billing programs. And when billing to Medicaid, telehealth billing guidance for Medicaid will depend on the state. So many Medicaid programs still require the GT modifier, but some may require the modifier 95 for certain services and or a telehealth place of service code. So when billing to private payers, they're commonly moving towards the modifier 95 for telehealth specific codes and the GT modifier for in-person codes. Before submitting a claim to your organization should review telehealth billing guidelines with each and every one of your payers because they are different. Although a private health plan may not be required to reimburse for telehealth services, they'll usually negotiate a telehealth contract with providers who can make the case that telehealth can improve their clinical outcomes and reduce wasteful spending for them. And that covers insurance and reimbursement. I'll go ahead and hand it over to Helen Lanes, our operations manager. Thank you. Thank you, Amanda. So I'm Helen Lanes. I'm the operations manager here at Sion Clinical. So my portion, I'm going to go just basic overview of technology for telehealth. There is a lots of in and outs. So like I said, it's an overview. We won't go down to the nitty gritty because that's more of a information technology specialist. So first off, I'm going to go over just the basic 3 topics I will focus on, which is software, devices, and then also resources. Telehealth technology has been around for decades and to connect patients with clinicians and has evolved drastically over the years and in price, functionality, mobility, usability. So we're coming a long way and we're going fast, but if you have the basic structure of technology, you'll definitely be able to start your telehealth project. So basic software, it's video conferencing. So it's a platform that consists of variety softwares to establish a face-to-face video connection for real-time telehealth encounters. One of the basic ones used all the time is Skype and FaceTime. And this does establish a face-to-face video connection, although it's generally not considered suitable for telehealth due to the lack of business associates agreement. And we'll discuss that a little bit more later. And I'll also provide a list of suitable video conferencing vendors at the end of my section. There are 2 commonly known telehealth systems. One is called the traditional or legacy system, and this actually uses codecs to communicate with other codecs using uniform protocols or standards, kind of like codes. These are dedicated devices, so sometimes they're on a cart or they're at a certain stable station. They're generally not mobile. And then these codecs, these devices, they exchange video and audio between each other. The only issue is if one codec is not using the same protocol or standard as another codec, they won't be able to connect to one another. And this certain system does require its own space and also routine maintenance. So it's a little bit downfall for using traditional or legacy systems, but it's still used today. The next one is cloud-based systems, which is growing greatly in popularity. They're less expensive, quick setup, and require little to no hardware on site compared to traditional systems. Minimal maintenance. You could just use your laptop, tablet, sometimes phone for this, and also the desktop with the camera. And lastly, there's even telehealth software that offers integration into current EHRs. This integration can streamline workflows for scheduling, documenting, and hosting. The level of integration will depend on the EHR and whether this partnership is available. Also, some EHRs may have their own telemedicine features, so that a separate software is not required for telehealth. I recommend if you already have
EHR system to look into that, the vendor, and see what's offered or what other vendors you could use with that EHR before jumping in and choosing a telehealth software. Some additional advanced features surrounding EHR and telehealth. In addition to standard video conferencing, more advanced telehealth management software is available and offer many more features to kind of help streamline your whole office setting. They allow you to do not just scheduling, but secure messaging, file sharing, electronic signing, virtual waiting rooms, billing integration, custom branding, notification, and provider directories, and also with notifications alerts, which is very handy when you're bringing up your telehealth program within your facility and how to manage patients and their visits. Average cost for telehealth management platforms can range greatly, anywhere from $35 per user per month to $150 per user per month. And some require a one-time setup fee, and that's on the side of the physician and the software that they choose. Listed here, I do have some examples of advanced telehealth management software. You can see that some you may have seen before: Adaptive Telehealth, AMD Global Telemedicine, VC, Synopsys. Those are good ones. Also, note when deciding on a telehealth software, it is important to consider compliance with HIPAA. We want to make sure that that is established when choosing a software. Again, that's why that business associates agreement is important between the platform you use and your facility. Now I'll dive into some devices. Here, they're not all listed individually, but this is a general overview of devices that may be applicable to your facility. There's off-the-shelf devices, which are everyday technologies such as desktop computers, laptops, tablets, and smartphones. These are commonly used for clinicians to join a telehealth encounter from a distant site. They're very handy nowadays, especially with cloud-based softwares. Next, we have telemedicine carts. These are dedicated telemedicine carts that are an all-in-one mobile solution for facilities. This tends to be the traditional software, so codecs or the legacy systems. Telemedicine carts include an onboard codec display screen, integrated peripheral devices if needed, high-definition camera, and external speakers and microphones. Next, we have field kits. They're like telemedicine carts, but field kits house everything needed for a telehealth encounter contained within a ruggedized briefcase-sized box. Field kits are generally used for home health services, disaster response, and isolated workplaces, such as an iron rig. Next, we have fixed stations and kiosks. Fixed stations are non-portable devices. So it's like the codec, just set up in one spot, that provide video conferencing utilizing codecs that resemble a desktop with the appropriate equipment to conduct a telehealth encounter. Again, something such as pan, tilt, zoom camera, peripheral devices if needed, microphone, and speakers. Kiosk is another form of a fixed station, but it's designed to sit in a public setting because it encloses, such as a grocery store, pharmacy, or in office for employees, and house all equipment for a telehealth encounter while providing adequate privacy. Here we have a couple of ways to improve user experience. So for instance, with a desktop or laptop, connecting, you want to make sure you have a high definition webcam, external microphone and speakers, or headphones. Headphones can really improve the user experience, both for who's conducting it and also the patient, vice versa. Also, the size of the monitor is important, especially if you need to use peripheral devices, you need to see something like a skin lesion or anything like that. The size of the monitor should be 22 to 24 inches to provide best visual. A monitor too large or small will distort the video quality. And with tablets, you might want to consider using a cart. Table mount can improve the visual while securing the device. So you don't lose it, or it's moving around. You don't want that interference with the video quality. And also you could sit back because you want to be able to see yourself in the image centered and look like you're looking at the screen as if you were looking at the patient, like they'd be in the office. Also, again, utilizing headsets or connecting to a wireless speaker and microphone could improve sound quality. Although most tablets, desktops, and laptops do come with some sort of speakers, microphones, or cameras that work pretty good. Additional features. So here we have, we're discussing a little bit more about store and forward telehealth. It's a little different from just streaming video conferencing. So there's two types. Store and forward is asynchronous connection. So medical devices periodically send data to central monitoring systems. This is generally used for e-consults when you want to do an e-consult on a patient. This is usually used for dermatologists or referring to a specialist. So you do a visit as if you're going to be doing it live, but you would store it and then send it to the specialist for review. Whereas synchronous is mostly all telehealth encounters. It's streamed, there's no lag, there's no store and then send it on later. And then with remote patient monitoring technology, these are kits that the patient is sent home with that include various devices to collect data about the patient, such as thermometer, blood pressure cuff, those sorts of things. This is beneficial for patients with chronic and/or complex health issues with software to guide the patient in collecting data back to the clinical staff and provide further engagement. And then this brings us to medical peripheral devices. There are various devices that are available to collect and transmit diagnostic images or data during a telemedicine exam, often operated by a telepresenter, as Dr. Shaw mentioned before, in the room with the patient. Devices include, but are not limited to, exam camera, stethoscopes, otoscopes, dermoscopes, EKGs, intraoral dental camera, and ophthalmoscopes. And listed here, I have additional resources, some examples of video conferencing vendors. Now you see here that Skype for Business is listed, so that one has a business associates agreement, so it is more HIPAA compliant. And then we have Zoom, which we're using today, and it is HIPAA compliant. There is some field kit, fixed stations, and kiosk vendors listed there, telemedicine peripherals. Some of these vendors are repeated because they provide a lot of support. And then also I want to mention a great resource besides the California Telehealth Resource Center is the Technology Assessment Center, also known as TTAC. They can review technology, assess user functionality, and they provide toolkits. They're a great resource for technology in telehealth. And I also want to note that I listed a bunch of vendors, but we're not affiliated nor recommend any specific one. That's up to you. These are just only examples and should not be considered as a recommendation or endorsement of Xeon Clinical. So that about wraps up my section. I want to thank everyone for my brief overview of technology. Obviously, there's way more we could get into, but with the limited time today, this is about it. Thank you.
Thank you, Helen. Okay, everyone, so it looks like we've gotten through the telehealth training course for today. I want to leave some time for questions. It looks like we didn't receive any questions except for one. Would it be possible to have a copy of the slideshow to refer to after for all the attendees today? Yes. I'll go ahead and send a copy of the slideshow to everyone who's joined today. And I'm going to give a few more minutes for any additional questions to kind of come in. And while those come in, I want to mention also some information about the evaluations. So it's really important that in order to qualify for your CME and CE credit for attending the course today is that you complete the evaluation form that I've emailed you all on your invitation today, and email it back to me directly. So my email address is aanello, AANELLO @sionclinical.com. I did email everybody today this morning with the evaluation forms. You'll want to complete one of the forms. So if you're an MD, complete the CME evaluation form. And if you have a PhD, LCSW, RN, anything else, you'll complete the CE form. So if you have any questions as to what form you need to complete, just feel free to reach out to me and ask. Once I receive your evaluation form back, I will return your certificate of completion, and then you'll be able to self-report for your CME credits. You'll be eligible for 2 credits for attending a 2-hour course today. Okay. And we're going to go ahead and check to see if there are any additional questions, and then we're going to shift the camera to the presenter who is going to be answering the questions. Have the presenter go up to answer? Yeah.
Okay, hi everyone. So the question is, do some patients in psychotherapy prefer audio rather than video? If so, how do you respond? Also, could you talk about patients who worry about their appearance or the appearance of their home? So I have had that experience, and I think that I just honor whatever the patient wants. If the patient prefers audio and does not want video, I just do a more thorough assessment over the phone. I want to know, in detail about their location. I want to know if they've been showering, since I can't really assess hygiene over telehealth. So I'm going to do, like I said, a more thorough assessment. And I'm reassuring, I think we just want to help the patient feel comfortable in whatever setting it might be. So if we're going to be using only audio over the phone, or if we're going to be using telehealth, how do we just acknowledge where the patient is at? Just reassure them. So if let's see, the question is, could you also talk about patients who worry about their appearance or the appearance of their home? I have had patients concerned about not cleaning up their environment in the back. They also have shown up with no makeup on, or, have even said that they haven't showered. And again, let's just reassure them. And I think also it might be worth exploring, tell me why you're concerned about that. How can I help you feel more comfortable? Anyway, we can probably go on endlessly about that question, but that's how I would respond. That's how I'd handle it.
Thank you, Aubrey.
I just want to add one thing, what Aubrey has said. I think as we go through COVID-19 pandemic, I think it's okay to use either audio or video or whatever the forms that we are using right now. But sometime in the future, when this emergency will be gone, hopefully one day, and CMS may revert the rag and go back to the original policy and interpret us and ask us to work on all the other requirements. In that, at that time, we are required to use an audio visual means for communications, which is HIPAA compliant, as Amanda, Helen, and other speakers mentioned. So that is something to take into consideration in the future.